Welcome to today's deep dive. Usually when we talk about a medical diagnosis, there is this underlying expectation of precision, right?
Oh, absolutely, yeah. Like, it's almost like engineering.
Right. You fracture a bone, they take an x-ray, and it shows that jagged white line. The clinician points at the screen and says, well, there it is.
Right, it's very binary. You can see it. And frankly, that's comforting for people, both clinicians and patients. They like pathology to be neatly categorized.
Completely. But the moment you step into the world of chronic pelvic pain, and specifically dyspareunia, that diagnostic clarity just totally vanishes.
It really does. It's incredibly murky.
Yeah, and that's because we're dealing with a dysfunction occurring inside a muscle group you can't even see. It's driven by these autonomic feedback loops that you cannot easily measure.
It is the absolute definition of diagnostic muddy waters. I mean, truly.
And today, our mission is to decode the exact clinician-led framework used to treat this. We're talking about SEMG biofeedback for uncoordinated muscle release.
Which is such an important topic. Because historically, the standard clinical advice for this kind of hypertonicity has been, well, pretty abysmal.
Right, and our source stack today really highlights that. We're looking at clinical guidelines from Europe, the UK's NICE guidelines, the Glaser protocol, and some really fascinating physical therapy data from the Children's Hospital of Philadelphia.
Yeah, when you look at those NICE guidelines, they point to a staggering failure rate.
It's wild. The data shows that when patients with these spasms are just given standard verbal instructions, like, just manage your pelvic floor, 70% cannot correctly isolate the muscles.
70%. Just let that sink in.
That means if a clinician just hands you a pamphlet and says, hey, work on your muscle control, the vast majority of you are essentially flying blind.
Exactly. And the clinical trial data gets even more alarming from there.
Yeah, because up to 30% of those patients aren't just failing the exercises. They are actively making it worse.
Right. Instead of isolating the pelvic floor, they default to what's called a Valsalva maneuver.
Which is like bearing down, right?
Yes, exactly. They increase their intra-abdominal pressure, they bear down, and they actively irritate the exact tissue sensitivity they are trying to heal.
Which is the literal opposite of what a hypertonic pelvic floor needs.
Precisely. If you're already dealing with reflexive guarding, adding repetitive downward pressure just feeds the dysfunction.
Okay, let's unpack this for a second, because verbal cues are practically useless here. I always think of it like, it's like trying to flex a specific muscle deep inside your ear.
Oh, well, that's a great analogy, yeah.
You cognitively know it's in there somewhere, right? But without a mirror to see it move, you have absolutely zero idea if you're actually doing it right.
You have no proprioceptive feedback. None.
So because patients cannot see these muscles to correct their movements, clinicians needed a way to make the invisible visible.
And that necessity is what directly led to the adoption of surface electromyography, or SEMG biofeedback.
So let's get into the mechanics of that. If a patient realizes herbal instructions are failing, what actually happens physically and neurologically when they walk into a clinic for this?
Well, the initial setup uses these highly specialized sensitive sensors. They capture the microscopic electrical signals from muscle contractions.
And they can be internal or external, right?
Right. Depending on the presentation, a PT might use vaginal or rectal sensors or just external skin patches next to the perineum.
But just to clarify, these sensors aren't shocking you or anything.
Oh, no, not at all. They are entirely passive. They aren't delivering a current. They're basically just highly sensitive microphones listening to the muscle fibers fire.
And then that raw electrical data goes to a monitor, which translates those microvolts into a graph or sometimes an auditory cue.
Exactly. And the presentations from CHOP, the Children's Hospital of Philadelphia, they actually call this a treadmill for the pelvic floor.
I love that phrasing. It makes it sound so normal. You're just watching your physiological output on a dashboard like on a Peloton or something.
Right. And what's fascinating here is that this relies on the principle of operant conditioning. By converting this internal process into an external visual line on a screen, you learn through trial and error.
Okay, wait. I want to push back on that term for a second. When we hear operant conditioning, we usually think of like a rat pulling a lever for a pellet.
Yeah, behavioral psychology.
Right. But dyspareunia isn't a behavioral choice. It's an involuntary autonomic reflex. So how does that translate?
That is a phenomenal distinction, and it really gets to the core of why this works. You're right, the spasm is a reflex.
Okay.
But the motor cortex of the brain still commands those muscles. The problem is the chronic pain has scrambled the sensory feedback loop.
So the brain is just getting the wrong messages.
Exactly. The brain thinks the muscle is relaxed when it's actually incredibly tense. So operant conditioning here isn't about rewarding behavior. It's providing substitute sensory input.
Oh, wow. So when you see the line on the graph spike, that overrides the faulty internal feeling.
Yes, it forces the brain to acknowledge, oh, I'm actually contracting right now, even though I don't feel it.
That is wild. It's like the screen acts as a temporary external nervous system.
Until the internal one recalibrates.
Yes.
That instant visual feedback creates rapid neuroplastic changes.
But having the tech is only part of the story, right? Because the sources outline that when clinicians first started using this for pain, they totally misinterpreted the data.
They were applying the wrong framework entirely. And this brings us to the pioneering work of Dr. Howard Glaser.
Right, the Glaser protocol. So what did he find?
Well, initially, he used standard biofeedback protocols designed for urinary incontinence to treat vulvar pain.
And the incontinence playbook is basically all about raw strength, isn't it? Just Kegels on steroids.
Pretty much, yeah. It's an up-training model.
Mm-hmm.
You want the highest possible microvolt reading, and then you drop back.
So he put these pain patients through the incontinence protocol.
He did. And neurologically, they adapted beautifully. They increased their strength. They reduced resting tension. The muscles got super fit.
But the clinical outcome was a total failure, right? The pain didn't go away.
It did not.
So what does this all mean? You're saying a patient could get a perfectly strong, fit pelvic floor, but still be in agonizing pain.
Yes.
Why? I mean, if they hit all the metrics on the graph, why does it still hurt?
Because strength was never the actual deficit. The failure of that approach forced Glaser to reevaluate the data.
So he looked beyond just the peak strength of the signal.
Exactly. He ran statistical analyses on the signal's architecture.
Uh-huh.
And he found the critical metric was the variability of the signal, not the strength.
The variability, so like how much the signal fluctuates while they're trying to hold a steady contraction.
Yes, measured clinically as the coefficient of variation. In patients with dyspareunia, their signals were incredibly erratic.
Even when they thought they were holding still.
Even then, the electrical output was spiking and dropping rapidly, and the harder they tried to flex, the more chaotic the signal got.
Okay, so what does that chaos actually mean at the tissue level? Why does a twitchy muscle cause so much pain?
It represents severe neuromuscular instability. Your pelvic floor has slow-twitch endurance fibers and fast-twitch phasic fibers.
Right, like a marathon runner versus a sprinter.
Exactly. In a healthy muscle, they fire in this beautifully orchestrated sequence. But in a painful muscle, it's like a sputtering car engine.
The fibers are just firing out of sync?
Yes, causing microspasms. The muscle is hypervigilant. So the new goal wasn't strength, it was to stabilize the signal and coordinate the release.
That makes so much sense. It's like a weightlifter who can lift 300 pounds but has terrible form versus a gymnast with perfect motor control.
That is a perfect way to look at it.
So moving away from strength, how do physical therapists actually structure a workout to get that stability?
This is where the Glaser evaluation protocol comes in. It uses a very strict 5-segment sequence.
Okay, let's break that down.
It starts with a 1-minute pre-baseline rest, just to capture ambient tension. Then phase 2 is 5 rapid contractions, or flicks, with 10-second rests.
I'm assuming those rapid flicks target the fast-twitch fibers.
Exactly. It tests how fast the muscle can initiate a contraction, and more importantly, how fast it can let it go.
Testing the reaction time of that guarding reflex. Got it. What's next?
Phase 3 is 5 10-second tonic contractions, again, with strict 10-second rests. This tests the slow twitch fibers and the ability to hold steady.
Right.
Phase 4 is 1 exhausting 60-second endurance hold. And finally, phase 5 is a 1-minute post-baseline rest to see how the tissue recovers.
Okay, I want to pause on those rest periods because the sources are incredibly emphatic about this.
Oh, they are militant about it.
Right. A 10-second hold mandates exactly 10 seconds of rest. The guidelines say you literally cannot build a muscle without rest. What is the physiological reason for that strict 1-to-1 ratio?
It comes down to localized ischemia and metabolic waste.
Ischemia meaning lack of blood flow.
Right. When a muscle contracts, it compresses its capillary beds, which stops blood flow. If a muscle is chronically hypertonic, it's always slightly ischemic.
So it's literally suffocating itself.
Yeah, and lactic acid builds up, which sensitizes the pain receptors.
Ouch.
So by enforcing that strict 10-second rest on the monitor, the PT ensures the capillaries reopen, oxygen returns, and the waste flushes out.
If you skip the rest, you're just training the muscle to stay irritated.
Exactly. You have to prove on the screen that the muscle has let go before you fire it again.
Which brings us to down training. Here's where it gets really interesting.
Yes, down training is the core of this.
Because it completely flips the traditional fitness script. Instead of pushing harder, the patient has to actively learn how to let go.
It's incredibly difficult. They have shortened, overactive muscles. The therapist has to guide them to watch the graph drop and then keep it dropped.
The cognitive dissonance must be huge. You have to stare at a screen to prove you aren't secretly clenching in anticipation of pain.
It's exhausting mental work.
Yeah.
And clinicians use specific techniques to help, like diaphragmatic breathing.
Because inhaling pushes the diaphragm down, which kind of naturally stretches the pelvic floor.
Exactly. They also use a cue called bulging.
Right. Bulging. That sounds like bearing down again.
It sounds like it.
Yeah.
But it's not a Valsalva push. It's a very gentle outward volumetric expansion, just a relaxation that slightly stretches the fibers.
And the monitor approves if it's actually lowering the resting tone.
Right. And they don't just do this lying down. The physical therapist will manipulate the exercise posture too.
Oh, right. Because doing this supine is totally different than standing up.
Completely. The moment you stand up, gravity enters the equation.
The pelvic floor suddenly has to hold all your organs up.
Right. The neuromuscular demand skyrockets. You might have a perfectly stable signal lying down, but you stand up, and the graph goes completely chaotic again.
So the biofeedback ensures you can coordinate that release in real weight-bearing life.
Exactly. It's highly rigorous.
But the sources also make it clear that clinicians rarely use biofeedback in isolation, right? It's part of a broader multimodal approach.
It has to be, because biofeedback fixes the brain's signaling, but you still have to deal with the actual physical muscle tissue.
Right. The muscle has been locked in a spasm for years.
Yes. There are physical crosslinks and shortened sarcomeres that need mechanical intervention. That's where manual therapies come in, specifically theal massage.
Let's talk about theal massage because it's cited a lot in these outcomes. It's an internal digital release, right?
Yes, typically sweeping along the levator ani muscles.
So mechanically, what is the therapist doing during that?
They are performing targeted deep tissue myofascial release. They apply rhythmic pressure to mechanically break up those knotted fibers that refuse to let go.
So they're physically forcing the tissue to elongate.
Exactly. When you combine that physical release with the brain retraining from the biofeedback, you attack the spasm from both ends.
That makes total sense. And the sources also talk about using SEMG with vaginal dilators.
Yes, which is a brilliant piece of engineering.
Yeah, these aren't just standard dilators. They are medical-grade silicone. They weigh exactly 37 grams, and they have a little steel ball inside.
Right.
Why 37 grams? And what's up with the steel ball?
It's all about passive proprioceptive enhancement. 37 grams is heavy enough that you feel it, but light enough that it won't trigger a massive pain reflex.
Okay, and the ball?
As you move around, the steel ball creates these tiny, unpredictable micro vibrations inside the device.
Oh, wow.
Yeah, it triggers the mechanoreceptors. It forces the pelvic floor to make constant involuntary micro adjustments to hold it in place.
So it's like a mechanical form of biofeedback you can use without staring at a screen.
Exactly. It continuously feeds sensory data to the brain to improve coordination.
That is so clever, but we also have to touch on the psychological side because cognitive behavioral therapy, or CBT, is frequently mandated alongside this.
Oh, it's absolutely crucial. You have to address the psychological overlay of chronic pain.
Because if you've had severe pain with intimacy for years, your brain literally wires sex directly to a fear reflex.
It's a classical conditioning response.
Yeah.
CBT gives the patient the tools to disconnect that anticipation of pain from the physical autonomic spasm.
So if we pull all this together...
If we connect this to the bigger picture, the clinician isn't just treating a symptom. By mechanically resetting the tissue, stabilizing the signals with biofeedback, and addressing the fear loop with CBT, they are dismantling an entire autonomically mediated pain cycle.
And the results really back that up. Let's look at the stats.
They are incredibly encouraging.
In Dr. Glazer's original cohort, there was an 80% resumption of intercourse for patients who were previously totally abstinent due to pain.
80% is massive for a condition like this.
And the follow-up studies confirm it. McKay's 2001 study showed a 69% resumption rate.
Right. And more importantly, by the end of treatment, nearly 89% reported their pain was either negligible or just mild and manageable.
An 89% success rate for something that is notoriously misdiagnosed and difficult to treat.
It completely validates moving away from just telling people to do Kegels and embracing this objective, real-time data.
It proves that uncoordinated muscle release is a treatable physiological dysfunction. Which really brings us to why you, listening to this, should care. Even if you don't deal with pelvic floor dysfunction, this whole deep dive proves how wildly unreliable our internal body awareness can be.
Oh, completely. We assume we know what our muscles are doing just because we live in our bodies.
Right. But chronic pain can completely sever that conscious awareness.
It's a huge blind spot.
And it challenges that whole no pain, no gain mentality. Sometimes blindly trying harder, bearing down, forcing a contraction.
That's the absolute worst thing you could do.
Exactly. True coordination requires the ability to consciously let go.
You can't force it.
Yeah.
Sometimes you literally need a screen to show you that your internal map is wrong before your brain can fix it.
Which leaves us with this final, truly provocative thought to mull over. We've just mapped out how biofeedback rewires a chronic pain reflex just by making invisible tension visible, right?
All right.
So if watching a microvolt reading can dismantle a chronic pelvic spasm, could this exact same visual mapping be the missing key for other mysterious chronic pains?
Oh, that's a fascinating question.
Right. The ones we always dismiss as just stress or psychosomatic because an X-ray can't see the tension. If we could instantly see the invisible spasms in our lower back or our neck or our jaw on a monitor.
So we just learned to downtrain those cycles.
That's exactly. Just something to think about the next time you have a persistent pain that no standard scan can seem to find.